Good morning, everyone, and welcome to our first keynote session for SAPC 2021. I'm Rebecca Beacon, an Associate Professor of Behavioural Medicine here at Leeds, and I'm really delighted to have the opportunity to introduce our first speaker, Professor Paul Aveyard. As many of you will know, Paul is a GP and Professor of Behavioural Medicine at the University of Oxford. He's led a number of significant studies in the area of behaviour change for disease prevention and management, and particularly looking at smoking cessation and weight management support. Today, he's going to be addressing a highly topical question within primary care. Is primary prevention practical and desirable? And just a reminder that there will be a Q&A at the end of Paul's talk, so if you have any questions during or after the presentation, please do post these in the Q&A box on the right-hand side of your screen. Without further ado, it's my pleasure to introduce Professor Paul Aveyard.
Hello, can I do primary prevention? I think the answer is yes. Let me tell you about a trial in which we asked 137 GPs to give brief, opportunistic interventions to patients that were consulting that day and who had obesity. We weighed and measured everyone attending to see our trial GP, and the large majority of people enrolled. As is common in many of our studies, the patients did not know what was going to happen to them in the consultation. 1,182 people were enrolled, and doctors were asked to say, while you're here, can we just talk about your weight? Did you know that the best way to lose weight is to go to a weight management program like Slimming World? And that's available free on the NHS. Oh, yes, and I can refer you now if you're willing to give that a go. Okay, sure. Great, take this form outside and I'll book you into a program right now. In the control condition, doctors gave advice that losing weight would benefit health. Are you willing to give it a go? 77% said yes. 40% attended the program, and across the whole population, not just those attending the program, there was a 1.4 kilo difference at 12 months. Now that may not seem like much, but this is a highly repeatable intervention. And if it were repeated annually over 20 years, it would halve the prevalence of obesity in the UK and reduce the incidence of diabetes and cardiovascular disease by 20%. And it would take the average GP about 3 hours a year. And this intervention is cost saving through reduced incidence of disease. This is the cost effectiveness plane. And in medicine, we're usually in the yellow quadrant. But here we have something that improves health and reduces costs, and we're in the blue quadrant. And the same is true, by the way, for brief smoking cessation interventions. Now, any rational doctor ought to do brief interventions first and most, and only do any of the other stuff when she could do no more of those. But we are not rational choosers in this respect. We have structures like NICE and so on that give us the illusion that we practice medicine rationally. But really, something else is underpinning the way we behave as clinicians. This is a very old slide that I used to put up and then proceed to knock down the bricks in this wall one by one, showing that it's easy and effective to do brief opportunistic interventions. And I hope I've done that for you already. Now, this systematic review was about doctors' views of brief interventions on smoking, and we've just published one on obesity where doctors gave exactly the same reasons for not doing them. More troubling to me, though, is the doctors in our trial. We asked them, how was it for you doing those brief interventions? And typically they said, well, I was nervous at first, but I got into the swing of doing it and patients responded pretty positively and some of them lost weight. And later on, we asked the GPs, are you doing brief interventions now? The trial is finished. And they said, no, it takes too long. I worry about offending people. I'm not sure it works. These doctors had seen these barriers weren't actually there, but when asked, they gave the standard answer to the question, why don't you do this? A great study that illustrates this is by Kath Checkland and colleagues. They asked GPs why they weren't engaging with a CVD prevention program, and they got a range of reasons, many of which were similar to my brick wall. But what they also did was to hang out in those practices, and that revealed that the real explanations, which are described in this very nice paper, but the underlying conclusion was that the main reason was that GPs, the way that GPs understood themselves as doctors and the roles that they should perform, which meant they resisted this initiative. We tested this in a study we're writing up now called Digging Deeper, where we aim to find out what lay behind the bricks in this wall. And the answer, I'm afraid, fellow GPs, is not a lot. When pushed by the question, how exactly does obesity differ from hypertension? We got long, thoughtful silences, broken by someone saying, well, you treat hypertension with pills, which doesn't seem like much of a philosophical basis to define our work, does it? We give out pills. What does determine what we prioritize? The sociologist Dag Album shows that medicine is dominated by a hierarchy of prestige. As clinicians, we can rank the prestige of diseases, and I'm going to show you some high-ranking diseases now. And here are the low-ranking ones. And his work has been extended to medical specialties too, where, for example, cardiology is near the top and psychiatry is near the bottom. Now, Friedson argues that 3 factors underlie the prestige of a condition, and here they are, and I've added a 4th at the bottom of this list. And while this explains why we don't prioritize primary prevention through addressing, for example, obesity, it leaves the question of why is it stigmatizing in any case to have obesity, for example. The reason these diseases are stigmatizing is because we believe that people have brought it upon themselves through their own behavior. No one but them decided to drink too much alcohol or eat too much food. Our experience of life is one where we go through it and we choose what we do. We feel we are the ghost in the machine. So how does this feeling sit with what science tells us about ourselves? Take obesity. GPs typically believe that this person has chosen to do the things they've done that have led to their obesity, and there's not much they can do. But about 70% of the variation in who is and who is not overweight is explained by genetic factors. And the same is true for smoking or alcohol dependence or drug misuse. This isn't some mysterious genetic force that operates in the way of, I only need to look at cake and I pile on the pounds. Rather, genes increase appetite, and increased appetite leads to increased consumption. And this happens through a variety of biological pathways. But how does this sit with our own experience of choosing what we eat and how much we eat? In this study, a series of judges were deciding on whether to grant parole or not to a series of prisoners in hearings through the day on the x-axis, and on the y-axis is the proportion of judgments that favoured the prisoner. Now, the circles represent the first cases after breakfast, lunch, or tea. And the key to understand why this occurs is to understand what's going on in the judges' minds. It's doubtful that if asked, they would say, I was feeling bored and angry, so I decided to leave him in jail. Rather, for each case, there are reasons to be lenient. Everyone deserves a second chance. And there are reasons to be harsher. He's a recidivist criminal. What judges couldn't perceive, but the data appear to indicate, is that those judgments were driven by inner drives and not just the facts of the case. And if trained professionals with only one task to do cannot overcome their impulses, then what hope have the rest of us in the ordinary run of our lives? Einstein said, if the moon was conscious, it would believe it wanted to circle the Earth. This inherent belief that we make rational choices occurs because we have no way to observe our decision-making. We perceive only the input, mainly the facts that go into a decision, and the output, the decision or the choice itself. An analogy is walking through a busy city. Your brain somehow integrates all the visual stimuli and ensures you don't bump into people, and you still recognize your friend in the crowd. We don't know how we do this, we just know that we do, and so it is with choosing. So, I've shown you that primary prevention is possible, practical, and it's desirable from a rational perspective. But what holds us back is our sense that this is low-value work, stemming from an incorrect belief that people have chosen to be the way that they are, and there's nothing much that GPs can do about that. The values that underpin this are not the values that sit easily with many of us, and incidentally, it's a value system that puts general practice at the bottom of the prestige hierarchy. We can do primary prevention, and we can feel good about doing primary prevention if we are prepared to adopt into our worldview a scientific understanding about the basis of conscious behaviour. Thank you very much for listening.
Thanks, Paul. I think you've made a really strong case there that offering this kind of support is needed, but it's fascinating to hear how hardwired some of those perceived barriers are in this area. Please do post questions for Paul in the Q&A, but I'll start off with one. So given that you've very clearly articulated how none of us are rational choosers in our behaviour, what are the implications of that for how we approach behaviour change?
I think the implications are really that what you need to do is think, well, let's engineer the system so that it supports rather than leaves a person to sort of rationally choose something that they say they want to do. So let me give you an example. Some colleagues in America did this trial of very brief interventions for smoking cessation, and they randomized participants in the trial, and there was nearly about 2,000 of these people, to either say, you know, the best way to stop smoking is to go to a stop smoking service, or it's actually a quit line, to get in touch with the quit line. Here's the number, give them a ring. Or best way to stop smoking is to get in touch with a quit line, and I'll get them to ring you. Now, what actually happened in this trial is 20 times more people started with and engaged with a program of support to help them stop smoking when the quit line called them, versus compared with the other condition where they were left to call the quit line. And overall, and other studies have shown that this also leads to an increased rate of abstinence, sort of 4 or 5-fold. So as clinicians, we typically think, well, you know, if a person isn't motivated enough just to even ring up the stop smoking service, then they're clearly not going to quit. But actually, behavioural science is telling us the reverse is true. We can and we do stuff, and we can achieve hard goals like stopping smoking in the long term only if somebody organises for us to do it. And it sounds pathetic when you say it, but it's the way we behave, and we can engineer our systems to do that and support, for example, me as a clinician, by leaving the onus with the system and not on the patient.
Thanks. We've got loads of questions coming in now. So I'll start off with one that's quite popular from Claire Norman. Is there evidence that brief interventions work across the socioeconomic spectrum? I'm aware that we are less likely to deliver brief interventions in this population, but do they work when there are lots of wider factors at play?
Yes, there is. So in our trial that I very briefly presented at the beginning, we looked at this specifically, and we looked at all the various steps in the chain, as it were. So saying yes to the GP, having said yes, did you attend? If you attended, did you complete the course of, if we're going to call it treatment? And there was people who were of lower socioeconomic status were more likely to say yes, slightly less likely to attend, but the net effect of those two, given they'd said yes, but the net effect of those two forces was that there was no social class gradient. Where there was a social class gradient that emerged in the wrong direction, if you like, in favour of richer people, was that richer people were more likely to complete the course of treatment. Now, that's not something that we can do as GPs to do anything about that, but it sort of then puts the focus on what can we do to engage people from lower socioeconomic statuses to maintain contact with the service. And so there's work to do there in sort of, if it were, the completion side of things. But at the brief intervention side, the people from lower socioeconomic status were more likely to say yes.
Great. One one last question I think we've got time for. So a couple of questions about how we incorporate this into medical education. So incorporating behavioural science into medical education, or addressing some of these barriers.
Yeah, I try to do that here with our medical students, and then they're in the clinical years. And I suppose you've got to try to, what's so difficult about what I was trying to say is the feeling of being me is that I'm here doing what I want to do, and that's what happens, and so everybody else must be like that. But of course, the feeling of being me is some sort of deception of the brain to some extent, and we need to sort of build that into the way that we approach life. And if we as a world have less confidence in ourselves as rational choosers and less confidence in other people as rational choosers, then we can begin to be more forgiving, if you like, of people's weaknesses. We can begin to understand the way that complex social and genetic forces shape our environment in a way that's not perceptible. So we just need to sort of throw out our sense of self, and I think that's the foundation stone of everything else that might follow from that. And if you can get rid of that belief, there's room then for other beliefs to creep in.
Great, thank you, Paul, for a great talk and some great questions there. So thanks everyone for those. I'm going to hand over now to Adam Grice to introduce our next speaker.
Hello everyone, thanks to Paul and Becca there. My name's Adam Grice, I'm an NIHR in Practice Fellow at the University of Leeds and a GP. It's an absolute pleasure to introduce our next keynote speaker. But before I do so, just a reminder to please use the live Q&A section throughout the talk, and we'll give those questions at the end. Tom Williams is the Chief Operating Officer of Parkrun Global. In 2007, whilst working as a lecturer of sports and exercise science here at the University of Leeds, Tom helped start Woodhouse Moor Parkrun, which is an extremely popular parkrun event, which I, my friends, colleagues in our local community have benefited from. In 2011, Tom went to work full-time for Parkrun, which is now recognised globally with events all over the world. We'll now hear from Tom and some of the fantastic benefits to health that Parkrun offers.
Parkrun is a free, weekly, timed 5-kilometre or 2-kilometre event where anyone and everyone is welcome to walk, jog, run, volunteer, or even just spectate. On an average weekend pre-COVID-19, almost 400,000 people would take part across 2,200 locations in 22 countries. And since October 2004, 4.4 million different people have walked, jogged or run 61 million times at parkrun events, whilst 508,000 different people have volunteered 5.8 million times. Parkrun has been described as one of the UK's greatest public health initiatives. When Paul Sinton-Hewitt first created Parkrun back in October 2004, he was going through a difficult time in his life, and running was his coping mechanism. Not because of the miles he covered or the races he finished, but because of the people he spent time with. Unfortunately, he suffered a serious injury, which meant he wouldn't be able to run, and, faced with losing his social support network, he decided to invite his friends to his local park. They would run 5 kilometres, he would time them, and afterwards they would go for coffee. Despite at that time being called the Bushy Park Time Trial, it was in fact the Bushy Park social intervention for a lonely bloke having a hard time in life. I first met Paul in the summer of 2007, at which time there were just 3 parkrun events in the world, all in West London. Yet he said to me that day that wouldn't it be great if there was one of these in every town in the world? Quite a remarkable vision. From then on, Parkrun set itself the rather ambitious mission statement of a parkrun everywhere in the world somebody wants one. And it spread its wings, not only around the UK, but around the world. And by 2015, there were 500 parkrun locations and 100,000 weekly participants. Paul had received a CBE for his endeavours, and to all intents and purposes, Parkrun had achieved what it set out to do. Except it hadn't. By this point, we had realised the incredible opportunity in front of us to improve the health and happiness of people around the world, people who didn't know that parkrun could play such an important role in their lives. Looking back at the impact we were having, it was always around friendships, roles within community, and the re-establishment of a feeling of connectedness with fellow human beings. And for some time, our daily decisions had been based on improving health and well-being, and not on a parkrun everywhere somebody wanted one. For example, we'd turned down a significant financial sponsorship offer from a sports drinks company because, although we needed the money, we knew that sugary drinks were not only unnecessary, but bad for people, rotting children's teeth and increasing risks of developing obesity and type 2 diabetes. So we changed our mission statement to a healthier and happier planet. And now, every decision we make is consciously placed within that statement. Since then, we've grown to the 400,000 people per week across the 22 countries, and pre-COVID we were growing at around 20% per year. We have events in Siberia, Soweto, San Francisco, and many places in between. Within a few years' time, we expect to be at 1 million participants per week across 5,000 event locations. And we have plans to accelerate that growth beyond that point as we continually develop our processes in order to make them more streamlined, more sustainable, and more effective. But it's about so much more than the numbers. When we started Woodhouse Moor Parkrun here in Leeds in October 2007 as the 4th event in the world and the first one outside London, we did so with the aim of engaging the university students with a wider community around volunteering and sport. At event number 1, we welcomed 15 walkers and runners plus a handful of volunteers, with everyone having a great time, meeting new people and enjoying being active. Since then, we've delivered 660 events in that park alone, with 26,000 people taking part 211,000 times. On its own, and without any other form of modification, that's an incredibly powerful public health intervention in its own right. On the 500th running of Woodhouse Moor Parkrun, people were asked to write down what parkrun meant to them, and the responses were truly overwhelming. But there's so much more potential within parkrun, and so many more people desperately in need of opportunities like parkrun, and we need to work hard to reach them. Several years ago, I was privileged enough to meet a parkrunner who had previously lost his sight while in his 40s. He described how the condition he was living with meant that his eyesight would deteriorate over time, about how he'd explained to his daughter that soon he would never be able to see her again, and how once he lost his eyesight, he'd spent 6 months either in bed or sat on his sofa, at home, alone, isolated and excluded from society. Our communications channels will never reach people like that. They will never know about our events, and even if they did, they would never think it's for them. Fortunately, this person's GP did know about parkrun and persuaded them to come along. Sometime later, their life had been turned around, and that parkrun event had won an award for the work they were doing to engage people with visual impairments. What that experience taught us is that we cannot make the world healthier and happier on our own. We do not have the skills, expertise, knowledge or influence. So if we really are going to make a positive dent on global health and well-being, we need to work with other equally passionate organisations and individuals. In recent years, we have focused on female participation as walkers, runners and volunteers have seen a slow but steady increase in the percentage of parkrunners who are female. We've worked hard to encourage previously inactive people to come along and have seen our average finish time get slower for 16 consecutive years, something we celebrate very publicly. And we've focused on disadvantaged communities, particularly at junior parkrun, and now have successful parkrun events in some of the most challenged areas of the United Kingdom. Where we've struggled, however, is with specifically engaging those most in need and therefore with most to gain. We've attempted to roll out a programme of guide runners for people with visual impairments. We've developed an outreach programme for people living with long-term conditions and disabilities. And, particularly globally, we've tried but struggled to meaningfully engage with remote and isolated communities. There are situations where we know there is particularly poor health and well-being, and parkrun could be part of the solution. But we've been unable to directly engage with target groups to the level that we know is possible. Over the last few years, however, we have made good progress toward developing strategic partnerships that we are convinced present the solution to this problem. In 2018, we partnered with the Royal College of General Practitioners with the aim of improving the health and well-being of healthcare staff, patients and carers, reducing the need for lifelong medication. GP practices are encouraged to develop closer links with their local parkrun events and to become certified parkrun practices. In the first 2 years of the Parkrun Practices project, over 1,500 GP practices have registered with us and are now encouraging their patients to come along and participate. Across the country, GPs are brilliantly connecting us with members of their community who we otherwise would never have reached. In another great example of successful collaboration, an initiative called 5K Your Way was created by Lucy Gossage, an oncologist in Nottingham, and Gemma Hillier-Moses, founder of the Move charity, who herself was diagnosed with cancer at the age of 24. This initiative piggybacks on parkrun events where we provide the ecosystem within which the 5K Your Way groups participate by coming together once per month at their local parkrun event. Although small, these groups are providing incredible levels of benefit to the people they engage with, and not only are they able to utilise the event delivery of parkrun events at zero cost to their organisation, but the groups themselves benefit greatly from being part of and integrated with a broader community. As we look to the future of parkrun, not just in the UK but around the world, and particularly as communities get back on their feet after the COVID-19 pandemic, initiatives like parkrun have never been more important. Whilst to a level, parkrun can be successful on its own, in order to truly realise its potential, it is critical for us to achieve a joined-up and collaborative approach where the skills, knowledge and expertise of many different organisations are pooled together. In the right environment and with the right culture, we really can make the world a healthier and happier place. Thanks for listening.
That's great, Tom. Thanks for that talk. Just a reminder to everyone, if you could just start putting your questions into the Q&A, we'll be able to ask them to Tom. We've got a question to start from Richard Neal, who also states, thank you for all the amazing work you're doing, Tom. The question is, how can parkrun engage more with harder to reach sectors of society?
Thanks, Richard, and thanks, Adam and everybody, for the opportunity. I think it's a really good question that we don't totally know the answer to. So as I kind of alluded to in the talk there, I think, we always felt at the beginning of parkrun that all we needed to do was put a parkrun event in a park and that was it, and everybody would come and it would change everybody's life. And what we found over the years is in some places, like we found with female participation or less active individuals in general, we've been able to have really, really good impacts at scale. Actually, when we've looked at the more targeted groups and that are more difficult for us to engage because they don't have access typically to our channels, that's been very hard. And I think a lot of it will be about collaboration and working with really good organisations like the Royal College of GPs to really engage at a local level with those with most to gain.
Right, thanks, Tom. Next question is from Amelia Taylor. She says, do you think that virtual events such as the Melton Mowbray virtual parkrun have a part to play post-COVID restrictions?
Yes, I do. In a way, I think the Melton Mowbray virtual parkrun was very good, and we've, for the first proper time in parkrun's history, we've done a lot of virtual parkrun stuff with what we call not parkrun over the last year and a half, and I think we've had about 10,000 people register for and take part in a virtual parkrun, having never ever participated in an actual parkrun. So that's really exciting, and we're looking forward to engaging those people. I think what's really, really important, however, is that human interaction, real life, in-person human interaction, is absolutely critical, in my opinion, to the health and well-being of an individual. And so I think certainly in our world, the end game for us is always to get people together, moving, outdoors and social. And we think those three things are critical together. So yes, I do think virtual opportunities are really valuable and really important. I would hope they're a stepping stone to real in-person engagement, though.
Next question, Tom, is from a John Campbell. It's a really interesting question. And John starts off by saying, amazing work, lovely presentation, thank you. They've thought recently about parkrun and long COVID. Do you have any thoughts about that? And that's obviously a tough question.
Yeah, it's a really good question, that, and I think we've got a couple of staff members who are experiencing long COVID symptoms and have been over the last few months as well in our relatively small staff team, and across our global network of 7 million registered park runners. I'm sure that's significant. I think a big part for us is trying to understand what the impact of the pandemic has been and continues to be before we try and develop in further interventions. We are in a number of conversations about how we engage with national and international public health bodies and stakeholders around understanding the impact of things like long COVID within the parkrun community. And so hopefully as we move forwards, we'll be able to do that more. We have a parkrun research board, which is sort of semi-independent parkrun, which receives requests from research groups to do research. It could be on anything to do with physical activity and health, and we support an awful lot of research through that. It's a free, we make our appropriately make our data freely available to researchers through that research board. And I really do hope that we will be able to not only support work towards reducing the impact of long COVID going forwards, but also hopefully help develop understanding of, particularly regarding the impact on physical activity, what that means for wider physical activity interventions going forwards. Great question.
Thanks, Tom. Brilliant talk, and thanks for being with us. It was lovely to hear you talk about parkrun, and I know I personally am looking forward to it returning back in the UK soon, and I'm sure everybody else is.
Thank you.